Hello everyone. Today we'll be talking about trauma from occlusion. So let's first talk about let's first know about the definition of the trauma from occlusion. So according to Glickman in 1974, when the occlusion forces exceed the adaptive capacity of the tissue injury results, and this resulting injury is known as trauma from occlusion. Now, it is generally accepted that plaque is the primary cause for the initiation and progression of the periodontal disease. But the early investigators and clinicians assigned an important role trauma to occlusion, trauma from occlusion in the etiology of the periodontal issue. Since then, numerous studies have been performed in attempt to determine the mechanisms by which trauma from occlusion may affect the periodontal diseases. Kerala in early 20th century was the first to publish the relationship of the occlusion forces to periodontal disease. Stillman in 1920 was one of the early pioneers of periodontal therapy, presented the proposition that excessive occlusive stress was the cause of periodontal diseases. Winman in 1940 and then Glickman in 1965 and 67 became that pathway of spread of plaque-associated gingival lesions can be changed if forces of an abnormal magnitude are acting on the teeth and the interdental or subgingival plaque. Okay. So, understanding of the principles of the occlusion and its relationship to the oral health and the disease has become necessary. We all know that occlusion forces is a critical factor which affect the condition and structure of the periodontia. The periodontal ligament alveolar requires mechanical stimulation from the occlusion forces in order to remain mechanically sound. So this occlusion force is an essential force. What happens? This occlusion force, when it is insufficient, the tissues undergoes atrophy. And when this force exceeds the physiological adaptive capacity of the tissues of the periodontium, an injury of the tissues and the bone results, and such trauma is trauma from occlusion. So the bone and the periodontal tissues have some capacity to withstand this occlusion force. And when this occlusion forces goes beyond the adaptive capacity of the periodontal tissues, then injury occurs to this periodontal structure. Okay? So the dependence of the periodontal tissues on the trophic stimulation from the occlusion forces in periodontal health makes occlusion a critical environmental factor. So just we'll go through the definition of what is an occlusion. Basic definition by Edward Engel in 1899 defines static concept of occlusion as the relationship between the occlusion surface of maxillary and mandibular when they are in contact during function or when at rest. His name is occlusion. So now we will go further and how we will know what is the how does the periodontium accommodate or adjust to these occlusion forces which which it encounters in our day-to-day life when we are biting, when we are talking, when we are swallowing. So there occurs an inherent margin of safety that is common to all tissues of the periodontium that permits variations in the occlusion forces without adversely affecting the periodontium. However, when these occlusion forces exceed the adaptive capacity of the tissue injury results, and this resultant injury is termed as trauma from occlusion, which is known as occlusion trauma. So, in simple words, what we understood is that our periodontium has a range of or a margin up to which it can bear the forces of the occlusion. Okay, and when this forces of occlusion they are they goes beyond this adaptive capacity or this bearing capacity of the periodontium. The periodontium is now no longer able to accommodate these excessive forces, and hence it suffers an injury. Okay, and this resultant injury is known as trauma from occlusion. So it is not the occlusion, it is the injury which occurs because of the trauma. So it is a trauma from the occlusion. So how does it accommodate? it accommodates with the help of the periodontal ligament, which have the cushioning effect when the forces are applied to it. So the periodontal ligaments, they reorient themselves when excessive forces are applied. They increase in number, they increase in width, and they absorb the shock or the forces which are applied. And then they transfer these forces to the equilibrium. And when this capacity, they do till the maximum capacity. And when the forces are more than that, there occurs an injury in these ligaments and also in the alveolar bone. There occurs a resorption. There occurs eruption of the bone. There occurs destruction of the periodontal fibers. Okay. And then what happens if these forces are not removed or there is not cured or it is persistent, then it may lead to necrosis, it may lead to abscess formation also. But if these forces are removed, it may again go back to its normal. So symptoms of the trauma from occlusion develop only in situations when the magnitude of the load elicited by occlusion is so high that the periodontium around the exposed tooth cannot properly withstand and distribute the resulting forces with unaltered position and stability of the tooth. So we have understood the term adaptive capacity of the periodontium, which is very essential. And when there is this adaptive, when the forces are within this adaptive capacity, there is the periodontium is normal. But when the forces goes beyond this adaptive capacity, occurs trauma from occlusion. These are the definitions given by some authors like Stillman. He says trauma from occlusion is a condition where injury results to the supporting structures of the teeth by the act of bringing the jaws into the closed position. Now, the changes in the periodontium because of these occlusion forces depends on the magnitude, direction, duration, and frequency of the increased occlusion forces. The inherent margin of safety occurs in the periodontium. Okay, but changes in the periodontium, when there are changes in the magnitude of the occlusion force, when there is a change in the direction of the occlusion force, when there is a change in the duration of the occlusion force, like it is constant or it is intermittent, and when there is frequency of the occlusion forces, all these factors change the adaptive capacity of the periodontium. So when the magnitude of the occlusion force is increased, the periodontium responds with widening of the periodontal ligament space, and increase in the number and width of the periodontal ligament fibers, and increase in the density of the alveolar bone. So magnitude of the force जब increase होता है, तो periodontium it responds. How does it respond? It responds with the widening of the periodontal ligament space. जो periodontal ligament space है, वो widen हो जाता है. Okay. So, increase in the number and width of the periodontal ligament fibers, the number and width increase which occur, and there is an increase in the density of the alveolar bone. Because the tooth shifts its position, there are changes which occur in the pressure side, there are changes that occur on the tension side, and it leads to increase in the space, okay, in the area where there is a pressure, there is a pressure side, and in the tension side, there is compression of the, there is increase in the periodontal ligament fibers length. Now, changing the direction of the occlusion forces causes a reorientation of the stresses and strains within the periodontium. The principal fibers of the periodontal ligament are arranged so they best accommodate to the occlusion forces along the long axis of the tooth. Lateral or horizontal forces and torque or rotational forces are more likely to injure the periodontium than the axial forces. So, if the direction of the occlusion force changes, the reorientation of the stresses and strain occurs, and this is being done by the reorientation of the direction of the periodontal ligament fibers. Response of the alveolar bone is also affected by the duration and frequency of the occlusion forces. Constant forces on the bone is more injurious than the intermittent forces, and more frequent the application of intermittent force, the more injurious force is to the function. So, if the frequency or if the duration of the force is constant, if there is a constant force, so it will cause more injury rather than if it is an intermittent force. Similarly, If the frequency of the intermittent force is more, if the intermittent frequency is occurring more frequently, so more injury will occur to the periodontium. Now, the physiologic adaptive capacity of the periodontium to occlusion forces. The periodontium attempts to accommodate the forces exerted on the ground. The forces, when we are transferred from the crown to the periodontium. Now, this periodontium attempts to accommodate these forces. Now, we have already studied. Okay. Now, this adaptive capacity to accommodate the forces is different in different persons, and it can be same. It can be different in the same person at different times. When the occlusion forces decrease the adaptive capacity of the periodontium, we all know the injury occurs. Now, according to the glossary of periodontal terms, American Academy of Periodontology 1986, traumatic occlusion is any occlusion force that exceeds the adaptive capacity of the periodontal bud. So, traumatic occlusion is any occlusion force that exceeds the adaptive capacity of the periodontal bud. Now, it can be caused as a result of preliminary contact, okay, parafunctional habits like clenching teeth or bruxism, or migration of teeth due to tooth loss. So, any traumatic occlusion may cause occlusion process that may change the adaptive capacity of the periodontal apparatus. And this traumatic occlusion may be caused due to premature contact or preliminary contact, parafunctions, and migration of teeth due to tooth loss. Now, synonyms of the occlusion trauma is used in practices is traumatic occlusion, periodontal trauma, traumatogenic occlusion, trauma from occlusion. So, trauma from occlusion is a tissue injury. It is not an occlusion force. It is a tissue injury. And occlusion that produces such injuries called as traumatic occlusion. So these are the terminologies given by different authors. Stillman, traumatogenic, traumatic occlusion, Box called as traumatogenic occlusion, Orban caused it as periodontal traumatism, Glickman called it as traumatism. Now we will go to the classification of the trauma from occlusion. Classification of trauma from occlusion, it can be classified in two ways. One, on the basis of the duration of the occlusion process, increased occlusion force. If it is of short duration, sudden, abrupt, it is called as acute trauma from occlusion. If it is of long duration, it is called as chronic trauma from occlusion. Then there is primary trauma from occlusion or secondary trauma from occlusion. It is primarily based on the based on the periodontial capacity. Like what we can say is that it is based on the capacity of the periodontium to resist the occlusion forces. Like if the periodontium is compromised or if periodontium is intact. So if the periodontium is intact, the primary cause from the trauma from occlusion is the increased occlusion force here. So it is primary trauma from occlusion. It is basically because of the occlusion, increased occlusion force, the periodontium is intact. But when the periodontium is compromised, so there may be two cases. Either the original occlusion forces are now not being beared by the periodontium. Here it is called as secondary trauma from occlusion. Also, if the periodontium is compromised, excessive occlusion forces may also cause a trauma from occlusion. So primary and secondary trauma from occlusion. So acute trauma from occlusion, periodontal changes associated with abrupt occlusion forces produced by biting on a hard object, for example, earlier, right? Restorations of prosthetic appliances that interfere with or alter the direction of the occlusion forces on the teeth. The periodontal, the prosthetic appliances or the restorations are such that they are causing either overhang, either it is preliminary contact or high points are there. So in that case, the direction of the transfer of the occlusion forces changes. So they may lead to acute trauma. So acute trauma results in tooth pain, sensitivity to percussions, increased tooth mobility, and it may cause segmental tears. So if the forces which are dissipated by the shift in the position of the teeth or by wearing away or a correction of the restoration, then the injury heals and the symptoms subside. So what we are saying, either it is corrected, the restoration or the prosthetic appliance is corrected, or if it is not corrected, the teeth adapt itself by wearing away, okay, or the tooth shifts its position. So in such cases, the force is being dissipated. Now the injury may heal and the symptoms may subside. But if none of these occurs, okay, then the periodontal injury may worsen and develop into necrosis, which may be accompanied by periodontal abscess formation, or it may persist in symptom-free trauma formation. So this is a slide showing features, clinical features, tooth pain, sensitivity to percussion, and tooth mobility, and depending on if these forces are being, if these things are corrected, it may lead to healing of the injury, and if it is not corrected, it may lead to further worsening of the condition. Chronic trauma from occlusion, it is more common than acute form of trauma from occlusion and is of greater clinical significance because it often develops from gradual changes in occlusion produced, and it occurs by tooth wear, drifting movement, extrusion of the teeth combined with parafunctional habits such as bruxism and clinching. Okay. So, not all malocclusions are necessarily injurious to the periodontium. The criteria that determines if the occlusion is traumatic is whether it produces periodontal injury. So, if the malocclusion is not produces any injury, so it is not traumatic occlusion. Only the traumatic occlusion is that which causes injury to the periodontium. So, it depends upon how the teeth are occluded. Now, this is a slide which is showing the difference between acute trauma from occlusion, trauma from occlusion, which occurs because of the abrupt force, and it develops from the gradual changes in the occlusion because of the tooth wear or drifting or extrusion of the teeth combined with parafunctional habits. Now, we will go to second classification, which is primary and secondary trauma from occlusion. So, trauma from occlusion can also be classified according to the capacity of the periodontium to resist the occlusion forces. They are classified as primary trauma from occlusion or secondary trauma from occlusion. Okay. So the trauma from occlusion may be caused, it may be caused by in two situations. It may be caused by alteration in the occlusion forces, or it may also occur when the capacity of the periodontium to withstand the occlusion forces is reduced, or third type, both are present. Okay. तो ट्रॉमा फ्रॉम ऑक्लूशन तीन कंडीशन में हो सकता है. ऑक्लूशन फोर्स का अल्ट्रेशन हो जाए, देयर मे बी अल्ट्रेशन इन द ऑक्लूजन फोर्स, सर्टेन एक्सेसिव फोर्सेस आ जाए या क्रॉनिक. सेकंड, जो पेरिडोन्शियम है, जो मेन है, जो व्हिच हैज द कैपेसिटी टू विथस्टैंड दिस ऑक्लूजन फोर्सेस इज रिड्यूस्ड. ओके. And third is both are present. There is alteration in the occlusion forces. Also, there is a change in the capacity of the periodontium. Okay. So, when the trauma from occlusion is the result only in the alteration in the occlusal forces and the periodontium is intact, it is known as primary trauma from occlusion. Whereas when its capacity is reduced to resist the forces, it is known as secondary trauma from occlusion. So this is a picture which is showing. This is a picture which is showing in first condition, the direction of the force is increased. Okay, direction of the force or the magnitude of the force is increased. But here the magnitude, here the periodontium is intact. Okay, so in such cases, periodontium is intact, but the forces are increased. So it is primary trauma from occlusion. Here the periodontium is compromised. You can see there is a bone loss, there is a recession. Even the normal occlusion forces, now it is not able to withstand the forces. So here it is called secondary trauma from occlusion. This is combined when the force is also increased, magnitude and directions are also changed, and also there is an adaptive capacity of the periodontium is reduced. So there are three types: primary, secondary, combined trauma from occlusion. In second case, it may be second condition also that the magnitude may be also increased. So primary occlusal trauma injury is resulting in tissue changes from excessive occlusal forces applied to a tooth or teeth with normal support. It occurs in the presence of normal bone level, normal attachment level, and excessive occlusal forces. So it may happen from insertion of high filling, prosthetic placement that creates excessive forces on the abutment teeth and antagonistic teeth, the drifting movement and extrusion of teeth into the missing teeth, and orthodontic movement of teeth into functional unacceptable position. All these changes produced by primary trauma do not alter the level of the connective tissue attachment and do not initiate the fit condition. This is because the supracrystal gingival fibers are not affected and therefore it prevents the micronutrition junctional. Now comes the secondary trauma from tissue injury resulting from the normal or excessive occlusion forces applied to a teeth or tooth with reduced pedophile support. Understood? It may be normal occlusal forces or it may be excessive occlusal forces. But here in this condition, the periodontium is compromised. So now it is not able to withstand the normal occlusal forces also or the excessive occlusal forces because its capacity is reduced. Okay? Secondary trauma from occlusion occurs when the adaptive capacity of the tissues to withstand occlusal forces is impaired by bone loss that results from marginal inflammation. This reduces the periodontal attachment area and alters the leverage on the remaining tissue. Okay? And the periodontium becomes more vulnerable to injury and previously well-tolerated occlusal forces become permanent. So understood? In secondary trauma from occlusion, because there is reduced capacity, there is bone loss, there is recession, the attachment fibers are also reduced to the area of the attachment, dental attachment. It reduces the leverage on the remaining tissue, and now the periodontium becomes more vulnerable to injuries. Combined trauma from occlusion here both the things occur. The forces are also increased. The direction is also increased. There may be jiggling type of forces or any type of forces increased from and coming from different directions, and also the periodontal support is reduced. Okay. So now we will talk about the clinical features and the radiographic signs of trauma from occlusion. This is very important. So the most common clinical sign of trauma up to occlusion in the periodontium is the increased tooth mobility. First is there is an increased tooth mobility. Second, there is pain on chewing or there is pain on percussion. Rhinitis is there. Occlusal prematurities or discrepancies are there. Wear is in the presence of other clinical indicators. There may be tooth migration, there may be chapped or fractured tooth, and there may be thermosensitivity. So these are the clinical features of the trauma from occlusion. So during the injury stage of trauma from occlusion, the destruction of the periodontal fibers occurs, which causes, because there is destruction of the periodontal fibers, there is a chances that there is an increase in the tooth mobility. During the final stages, the accommodation of the periodontium to increase forces entails a widening of the periodontal ligament, which also leads to increased tooth mobility. So it is saying when there is initial stage during the injury stage, okay, there is when the injury state, there is destruction of periodontal fibers. So it leads to immobility, and when in the later stages, when the periodontium becomes fails to adapt to these forces, there is widening of the ligament space to accommodate these forces. And here also tooth mobility is increased. Now, so this tooth mobility is initially not considered as pathology because it occurs as a result of adaptation. But if this injury is not cured, it then progressively worsens and then now it becomes pathology. Now, radiographic signs of trauma from occlusion. There is increased width of periodontal ligament space. Funnel shape occurs coronally. Thickening of the lamina dura occurs. Okay. Vertical or angular bone loss is there, and radiolucency in the furcation areas occurs, and also there is a root resorption which occurs. Okay. So that is all about the first part of